Hello everybody. So this is recording 2 of alterations in the GI system. If you're missing one, it's because you skipped the A&P review, which is again totally fine. So that will live on Moodle. If you again get down in it and you're looking at this stuff and you need that review, feel free to pop back over and watch my brief review on GI A&P. There are embedded, well, they're not embedded, but there are videos in the notes part of the PowerPoint if you want somebody else's voice, because I'm getting sick of my own, so I can imagine that you guys are too. So let's get started. So here, obligatory student learning outcomes, just be familiar with them. This is basically what I hope that you will be able to do by the time you are done listening to me. It's on the study guide / outline. Use them to kind of turn them into questions and be able to answer them at the end of this to see if you've got everything you need to. Okay. So we've done A&P review, so we're going to launch right into the assessment of the GI system and GI function. So the assessment for problems of the digestive system and the accessory organs is going to begin during history taking. So we talk about taking history. First, we're going to be looking at chief complaint in history. So page 647, I think, in your MedSurg book has a pretty good list of questions. It's a very long list of questions. But basically, we want to be asking about any family history of anything significant for GI. So any GI cancers, IBS, anything like that. We also want to be asking about diet, dietary intolerances such as lactose, any GI pain, bowel patterns, normal, not normal for them, any exposure to toxins or chemicals that might be impacting their GI system currently, and problems with blood clotting. So again, in A&P, and we'll get down into it a few lectures from now, the liver does impact, liver function does impact the way somebody can clot. So bleeding tendencies might be related to liver function, just something to keep in mind. We also want to verify any immunization status. Because of the many different functions of the liver, assessment of a patient with liver disease must include all of the systems of the body. So I know it seems like a lot, but the liver kind of touches on everything. So just be aware when you look at page 647, has a list of a lot questions. We also want to be looking at any laboratory values, any diagnostic testing that's been done. So we're going to evaluate the urine for the presence of bilirubin. This might make the urine dark or tea-colored. We want to be inspecting stool for the presence of fat or urobilinogen. I don't know if I pronounced that right, I'm sorry. If undigested fat is present, the stool will float in the toilet. And if bile is not reaching the intestine, the stool will appear clay-colored or whitish. So once we have gathered a bit of a history, we can move on to the physical assessment. So as far as inspection, we're going to start from the top. We're going to look at teeth, gums, and the oral mucosa. We're looking for any obvious issues. We should be examining the skin for color and as well as lesions, and note any discolorations on the abdomen. We're going to assess for overall symmetry of the abdomen, any scars, because sometimes patients forget that they've had massive abdominal surgery. It's happened to me. You go and you lift up somebody's shirt and they have this giant midline incision. I'm like, oh, I forgot to mention that I had giant surgery, 10 years ago. That's important to know. And again, we're going to be looking at the abdomen for any lesions or stretch marks, which could indicate recent weight gain. We're going to assess for the presence of edema and ascites. We're going to get into more detail about what exactly that looks like. But basically, it's a fluid buildup in the abdominal cavity. So to do that, we're going to be looking for marked abdominal distension. Taut, glistening skin will usually be there. I'll show you pictures. Assess ascites in the supine position with their arms at their side and their knees flexed. That is the best way to really kind of decide if what you're looking at is ascites versus just a nice rounded belly. If ascites is present, we should be measuring abdominal girth. If it's continuous, the abdominal girth will increase with subsequent measurements. So ascites isn't something that really goes away on its own, again, we'll get into more detail going on, but if somebody's belly is continually growing, they probably have ascites. For auscultation, of course, that's our next thing after inspection. We're going to auscultate the bell sounds for each quadrant of the abdomen. It's important to remember to listen to the belly before we start palpating or performing percussion, because palpation may cause peristaltic, this is the word I couldn't say in A&P, peristalsis, which otherwise might not have occurred. So if you're pushing on the belly, you might be riling stuff up, and you might end up hearing normal bell sounds when you go to listen if you palpated before you listened. So always look, then listen, and then you can palpate. For bell sounds, again, to be considered absent, it is necessary to verify that no sounds are heard after listening in each of the 4 quadrants for 5 minutes. That is a very, very long time to be listening to a belly. That's 20 minutes right there, in order for you to say that there are no bell sounds in that abdomen. So just make sure you're really hearing nothing and you're really listening for 5 minutes if you're going to claim an absence of bell sounds. Hypoactive bell sounds can be noted in the medical record when no sounds are heard after listening in each of the 4 quadrants for 30 seconds. That's more realistic. If you listen to somebody's abdomen for 30 seconds and you hear nothing, they probably just have hypoactive bell sounds. You'll probably hear something within that 5 minutes, but it's up to you if you want to listen to 5 minutes or not. If you're going to find some hyperactive bell sounds, they're going to be these high-pitched sounds, which are heard in one quadrant and generally going to be decreased in another quadrant. We should also be assessing for nausea and vomiting because the patient may have an intestinal obstruction. Percussion, this is not normally done. I don't think I've ever done it as an RN. You guys will probably never do it as LPNs. It's there if you want to do it. I think it might be included in the video we're going to watch in a minute, but again, not really commonly performed. And then palpation. So we're going to lightly palpate over each quadrant of the abdomen. We're looking to detect areas of tenderness, any masses that might be present. Important to watch the patient's face during palpation, because they might say nothing is tender, but you're poking on a certain spot and they might be grimacing. So something might be tender and they're just not maybe identifying it that way. So make sure you're looking at your patient, asking them questions, talking to them when you're palpating their abdomen, because usually their face will tell you first if they're having any pain. Important to note, if you see a pulsating abdomen, don't perform palpation. It's usually something you'll see before you go and start poking at their belly. So again, that's why we look before we start listening and palpating, because we're looking also for a pulsating abdomen or abdominal mass. This pulsation could be a signal that abdominal aneurysm, and those do have a potential of sudden rupture, so we don't want to go poking at it. So just FYI, those are out there. So, and there we go. On this video, this is a very, very thorough abdominal assessment. Take from it what you need. It's just good to watch, okay? And I think she switches halfway through, so just be prepared for that.
Hi, my name is Paige and I'm going to be your nurse today.
Hi.
So I'm going to ask you just a few questions right now.
Okay.
Have you had any change in appetite?
No.
Any change in your weight?
No.
Have you had difficulty swallowing?
No. No difficulties.
Are there any foods that you cannot eat due to allergies?
No.
Have you had any recent abdominal pain?
No.
Any nausea or vomiting?
No nausea or vomiting.
How often do you have bowel movements?
I'd say probably once a day.
Okay, can you explain their color and consistency?
They're pretty normal. Regular, they're brown usually, solid, nothing abnormal.
Okay, have you experienced any diarrhea or constipation?
No.
Do you have a history of gastrointestinal problems such as ulcer, gallbladder disease, hepatitis, jaundice, appendicitis, colitis, hernias?
When I was 13, I had an appendicitis and they removed it.
Okay, have you had any other operations to the abdomen?
No.
And have you had any history of x-rays?
No.
What medications are you currently taking?
I'm not taking any medications right now.
Okay. And how much would you say you drink alcohol?
I don't drink.
Okay. And do you smoke?
No.
Okay. Now I'd like to ask you about your diet. Can you tell me all the foods you ate yesterday, starting with your breakfast?
For breakfast, I ate one of the Greek yogurts with some granola. Lunch, I had like a chicken quesadilla, and then dinner time, I had a salad.
Okay. Would you consider that a normal?
Yeah, that's pretty normal. Yeah.
Okay. So you would say you eat healthy, unhealthy?
I usually try to eat healthy. Sometimes I'll occasionally splurge on like fast food or something, maybe like once a week. But other than that, I really try to, eat my fruits and vegetables and stuff.
All right. Okay. That's it with questions. Thank you.
Thank you.
Okay, so first I'm going to start with inspection. So I'm going to look at the patient's contour and look for symmetry, and hers is flat. I'm also going to look at the umbilicus, which is midline and symmetrical. I'm looking for aortic pulsations, and then I'm also assessing the skin. So I'm looking for any lesions, any scars, any obvious bulging or distension or ascites. So next I'm going to do auscultation. So I'm going to take the diaphragm with the stethoscope, and I'm going to listen to bowel sounds in all 4 quadrants. I'm starting with the lower right-hand quadrant and moving clockwise. And normally you would listen for 15 seconds in each quadrant. And she has normal active bowel sounds in all 4 quadrants. So next I'm going to take the bell of the stethoscope, and I'm listening for aortic bruits and also renal and femoral bruits. And she has no bruits.
Alright, so I'm going to do percussion now. We're just going to first assess for general tympany in all 4 quadrants of your abdomen.
Okay.
So I'm going to place my middle finger and just tap on it. Just make sure that there's tympany. Just in a circular motion. Yeah, all 4 quadrants have tympany. And then I'm going to go ahead and map the boundaries of your liver. So I'm going to start up here, and in the intercostal spaces, I'm going to percuss. So I'm going to hear your lungs at first, so there should be resonance. And then when I start reaching dullness along the midclavicular line, that's where your liver starts. So that should be about the 5th intercostal space. So what I'll do is I'll just make a mark here with a marker or something. And then I'll start from the bottom and I'll go up. So I should be hearing tympany here in your stomach along the midclavicular line. And then when I get to a dull spot, it's going to be where your liver starts. So I'll make a mark there, and then I'll just take something to measure it. And it should be between 6 and 12 centimeters for the normal size of a liver. And females, it's usually on the smaller side. And then I'm going to just percuss for your spleen. So that should be usually between the 9th and 11th intercostal space. So I'll just go near the bottom of her ribs, and I'll just percuss again here. And when I hit a dull note, that's where her spleen would be. So I hear it right there. And then I'm going to go ahead and just palpate your abdomen. So I'm going to do light first. So I'll take one hand and I'll just go in circular motions, like 1 to 2 centimeters, just to assess. Tell me if there's any tenderness that you feel.
Okay, no, none. Doesn't hurt at all.
And if she had mentioned any tenderness, I would just, for now, since I'm moving on to deep palpation with 2 hands, and it's going to be a little firmer, so if she had mentioned any tenderness, I would just go ahead and do that part last for the deep palpation, but she didn't, so I can just go ahead and do this. Just go in a circle around and make sure you get all the quadrants. I'm assessing for any bulges or masses or organomegaly. And everything feels normal. There's no masses or bulges.
So now I'm going to assess for different organs, their sizes, and any pain or tenderness of the organs. So I'm going to assess for the liver. I'm going to push down on underneath the ribs right here, and I'm going to ask the patient to take a deep breath. Can you take a deep breath so I can feel a little bit further? Some livers are palpable and others aren't. Normally they're not. You can't really feel them. So in hers I cannot feel. I'm also going to assess for the spleen. And I'm going to push down here and feel in the back. Any pain or tenderness?
No.
no pain or tenderness. There's also different tests that you can do to assess for appendicitis in the gallbladder. The first one is called rebound tenderness, and this is the Blumberg sign. And this test you want to perform at the end of the assessment because it can cause the patient some pain. So I'm going to push down on the patient and I'm going to release quickly. Any pain or tenderness?
No.
No pain or tenderness. So the next test is called Murphy's test, and this one shows the inflammation of the gallbladder. So I'm going to feel underneath, right by her liver, and I'm going to have her breathe in. And if there's any pain?
No.
No pain, so she's clear of that. And then another one is called the iliopsoas test, and this is where you lift the patient's leg, and you're going to push down the anterior thigh and ask them to resist you. Any pain or tenderness?
No.
Okay. And the last one is called the obturator sign, and this one also tests for appendicitis, where you bring the leg in and out, and you push down. Any pain or tenderness?
No.
Okay. So those are the tests that you do for the abdomen.
So like I said, very thorough. I don't expect you guys to do all of that. Just be kind of familiar with, that you need to look at the abdomen first before you start listening and before you start poking at it. Also be kind of familiar with some of those, tests regarding like Murphy's test and the test for appendicitis, the rebound tenderness, things like that. Those are things that you will probably frequently hear and you might eventually do. So here's some abnormal findings. So here on the top, we can see some distension or ascites. So again, it's going to be kind of that really taut belly. If you didn't know this was a guy, you might think this is a pregnant woman, but this is actually distension or ascites. I can't tell by looking at it. To me, it looks like ascites, I guess. But you won't really know that until you're doing further testing. And then on the bottom, we see asymmetry and bruising. So you can see on one side there, this person has a little bit of a bulge, and then there's some significant bruising around the middle there. If I had to guess, I would say that is probably from Lovenox or heparin injections. Those are blood thinners, for lack of a better term, and they do cause some bruising, especially if your patient rubs the area after you administer Lovenox. It's kind of instinctive to do, but they generally kind of look like a cheetah by the time you're done with them because they're all covered in spots. So some clinical manifestations of GI disturbance. What does that mean? These are some signs and symptoms you're probably going to be looking for when you're talking to somebody who's coming in with complaints of a GI issue. So the first one obviously is abdominal pain. So when we're assessing this, we want to make sure that we're asking all the questions we always ask as far as pain. So location. Is it in a specific quadrant? Like right lower quadrant might be indicative of appendicitis. Is it epigastric? Is it more heartburn related? Or could it be a potential rupturing aortic aneurysm? We want to know the quality of it. Is it stabbing, burning, dull or sharp, throbbing? Does it radiate anywhere? Sometimes gallbladder pain can radiate to the right shoulder. I don't know why. That's just where it goes. It's something to do with the nerves that innervate that particular part of the abdomen. We want to ask about intensity, so give them a pain scale, 0 to 10. Is it constant or intermittent? And then aggravating and alleviating factors. Does moving make it better or worse? Does eating make it better or worse? Pretty much anything that they can relate to making their stomach or abdomen feel better or worse is important. It'll be a clue for later. Other clinical manifestations are going to be anorexia. So most people think they know what this word means. Really, it's just the absence of appetite. Physical causes, excuse me. Physical causes of anorexia could be something as simple as some poorly fitting dentures, could be stomatitis, which we're going to go into in our first live lecture, could be decaying teeth, a bad taste in the mouth. One thing I want to make sure that you guys check for is the presence of thrush, which is basically a yeast infection in the mouth. I had one resident many years ago in my first position, and we thought she was just ready to die because she just stopped eating. we could find no rhyme or reason for it, and we were ready, like, literally to have, you know, hospice come in and see her because we couldn't get her to eat, so we thought she was just reaching the end of her life. Turns out she had thrush. We fixed her thrush, and I mean, this was like 5 years ago, and I know she's still alive. So just make sure that you're actually looking in the mouth, especially if someone is complaining of a decreased appetite, because it might not always be lower in the GI system. That is our problem. It might be way up high in the mouth. So some other causes of anorexia could be pain or nausea, or GI infection or irritation. Appetite is a really complex mental process. It has to do with associations and memory, which could be pleasant or unpleasant. I think if we all think back to a meal that we ate and maybe we're sick after, you probably maybe associate that. You might associate those two things together. I can't eat meatloaf to this day because I got sick after I ate some, and even the sight of meatloaf now makes me nauseous. So just know that, appetite is complex. There's a lot of stuff going on. It is stimulated by the sight, the smell, and the thought of food. Physical and social environment can also stimulate appetite or turn off an appetite. Mental depression can also cause anorexia. So there's a lot of things that go into it when someone says they just don't have an appetite. So dig further, get more information. As far as nursing management for anorexia, loss of appetite is pretty expected when a person becomes ill. Whenever you're sick, you might not always be real hungry for something. Persistent anorexia should be addressed to prevent consequences of inadequate nutrition. Nursing interventions are going to include mouth care before each meal to eliminate or minimize any oral physical causes of poor appetite. Laboratory results, including albumin and electrolyte levels, should also be monitored, because if somebody's not eating, they are at risk for electrolyte imbalances, and albumin is important and we need it. So if someone, again, is not eating specifically protein, they might be having an albumin issue as well. Make sure that you are documenting the percentage of each meal that a person is eating, so we know if they are eating more or less than they have been. If there's a psychosocial or cultural factors that are involved, potentially try offering preferred foods, as long as they're not detrimental to somebody's health. So in non-COVID times, we would always advocate for a patient's family to maybe bring in some home-cooked food, something that is culturally appealing to them, because sometimes people just don't want to eat hospital food or, nursing home food, and I've seen it. I can't always blame them for that. So next, flatulence and flatus. So the accumulation of gas can result from many things: surgical intervention, mechanical obstruction, accidental injury to the intestinal tract can all cause disturbances in the passage of gas. Pretty much anything that can constipate a person can also lead to a buildup of gas, which is very uncomfortable. Whenever ingested material cannot pass through the intestinal tract as it should, material accumulates in the stomach and the intestines. This creates pressure and distension when the peristalsis is decreased or the flow of chyme is inhibited by an obstruction. As far as nursing management, get that person up and moving. Walking around tends to move gas one way or another. Potentially Trendelenburg them if they are tolerating it. That's where you lay them on their bed and kind of tip their feet up. So in theory, gravity will bring gas to up. So if they are head down and feet up, gas will hopefully travel in the right direction. Abdominal massage for patients without any abdominal incisions can be done. Follow the lower intestine, work up the right side, across, and then down over the left colon to move gas towards the rectum, especially if someone's having decreased peristalsis. This can be especially beneficial. Advise the patient to avoid chilled or hot drinks. Kind of room temperature or tepid drinks is going to be the way to go. Very cold or very hot drinks can create more gas in some people. Antiflatulent medications, which contain simethicone, are helpful if the patient is not NPO. So we've all probably seen those commercials for, Gas-X. Sometimes that is a miracle drug for some people. Eruticate irritation. I'm probably saying that wrong. That's the fancy word for burping. I am never going to put that on an exam for you, but I don't know if you want to, impress family members next time. Find the correct pronunciation, because I'm sure what I just said is not it, but that's what it is. It's burping. Distension is abdominal bloating, typically related to a buildup of gas. So it's different than ascites. Ascites is fluid. Distension is mostly gas. Dyspepsia is the fancy word for indigestion or heartburn. It's going to be a discomfort in the upper abdominal area, usually described as burning. Also might be bloating or gassiness, some nausea, or feeling full too quickly after starting a meal. So, some people, they take 2 bites and they just feel very full. They're probably suffering from dyspepsia. Dysphagia, I think we've pretty much covered, probably to death at this point. The difficulty of swallowing. This person might need a modified diet, a speech evaluation, special eating precautions, something. Usually people have dysphagia following a stroke or a CVA. And then we're going to talk about diarrhea, constipation, nausea, and vomiting, all that good stuff. Maybe get my computer to work. There we go. So most of this is going to be a review from 103. So hopefully there won't be too much new information here, but I figure these are pretty common things, so we should probably touch on them again. So diarrhea is classified as the frequent passage of liquid or semi-liquid stool. Fun, right? Causes include a variety of illness, malabsorption syndrome, which we'll talk about, intestinal pathology such as ulcerative colitis or Crohn's, which we'll talk about, infections caused by a microorganism such as C. diff. Some surgery can cause diarrhea, food poisoning or food intolerance, mechanical or chemical irritation of the GI tract, excessive stress, poor diet, medications, and a general inflammation of the bowel can all lead to diarrhea. So diarrhea, not generally considered a disease, more of a symptom of a disease. Signs and symptoms, probably pretty obvious. Multiple liquid or semi-liquid bowel movements. We'll usually see some hyperactive bowel sounds, and they might also complain of some abdominal cramping. Potential complications of diarrhea, besides just not feeling good. Skin irritation is possible, especially if incontinence is present. Dehydration is going to be a potential secondary to excessive fluid loss from high amounts of liquid stool. Nutritional deficiency, if this lasts too long. Stool is being rushed through the GI system with, persistent diarrhea, so it doesn't have a lot of time to sit around and for nutrients to be absorbed. And then metabolic acidosis can also result from bicarbonate, which is lost in the stool. As the bicarbonate decreases, serum pH will also decrease, resulting in acidosis. Some signs and symptoms of metabolic acidosis are going to include lethargy, confusion, muscle weakness, bradycardia, hypotension, and a flushed, dry feeling. So generally, mild diarrhea is not going to be treated. It's usually a sign that something's going on in your body and your body's trying to get rid of it. If diarrhea persists for more than 24 to 48 hours, or if the number of stools is so excessive that great quantities of fluid are lost, treatment should begin. Antidiarrheal agents such as Lamodal, Imodium, and then there's one which is called kaopectate, which is kind of a different, it's like a combination drug. So again, we can give those sometimes after 24 to 48 hours if it's indicated. If the diarrhea is severe, nothing should be given by mouth until it subsides. This helps prevent increased peristalsis triggered by the ingestion of food. So we talked about that reflex in the A&P. Generally, when you eat, you're telling your body that, more food is coming and it should get rid of whatever else is in its system. So if someone has really excessive diarrhea, we shouldn't be giving them anything by mouth for a little while, so that hopefully, the body has a little bit of time to reset and it's not constantly rushing food through the system, resulting in diarrhea. If diarrhea is moderate, only clear liquids should be permitted by mouth, and severe, Long-term diarrhea may require the use of total parenteral nutrition, which we're going to talk all about. When diarrhea is caused by an infection, stool cultures and antibiotics may be necessary. And once the condition starts to improve, if that person has been NPO or on clear liquids, we can start to advance their diet a little bit. As far as nursing management for patients with diarrhea, we should be monitoring their intake and output and assessing the amount of fluid that's lost in the stool, measuring it if needed and able. We talk about hats. Those are, you put them in the toilet to generally catch urine. You can flip them around and put them in the back half of a toilet to collect stool as well. That is a good way to measure, especially liquid stool. Again, in nursing management, we're going to administer medications per order and replace any lost fluids, usually with IV. Monitor the patient for electrolyte imbalances and watch for signs of dehydration, such as decreased skin turgor, thick oral secretions, and a decreased urine output. Taking small amounts of an electrolyte replacement solution, Pedialyte, Gatorade, things like that can sometimes help prevent imbalances, especially in someone who is very prone, so the elderly or the very young. Avoiding coffee or tea can help because caffeine is a gastric stimulant and it increases peristalsis. Make sure to be performing thorough hand hygiene when caring for the patient with diarrhea, especially when infection is the known cause of diarrhea. Make sure you're following contact precautions to prevent the spread of infection. Really, this is talking about C. diff, which we go into a little bit, not too much. Antibiotics can kill harmful bacteria, but they can also eliminate the normal intestinal flora. So patients taking antibiotics can develop the bacterial infection called C. diff. It causes severe diarrhea, and people will generally need to be on precautions for C. diff. And they're not, according to your book, isolation precautions for C. diff are not the same as contact precautions. Where I work, it's basically the same thing, but it involves, most importantly, washing your hands with warm soapy water as opposed to hand sanitizer, because hand sanitizer does not kill C. diff. You have to actually physically remove it from your hands with hot soapy water. Warm soapy water. It shouldn't be hot. Warm sitz baths can sometimes help relieve soreness and discomfort in the tissues. Make sure you're helping the patient cleanse the area, avoid excessive wiping. Keeping the patient clean and dry is a high priority, helps prevent skin breakdown and promotes comfort. Odor in the room may be reduced with a deodorizing spray and by emptying and cleaning bedpans and commodes quickly, often, thoroughly. Please do that because no one likes to sit in their room with the smell of stool. Least of all us, right? So some treatments. First and foremost, we need to be identifying the cause and create a treatment plan from there. It's really hard to treat a diarrhea that you don't know why a person is having it. So try and get to that causative factor and treat that as opposed to just giving somebody an antidiarrheal, which is really treating the symptom. We need to know what's causing the diarrhea. We can modify the diet by using a brat diet. It's going to be low fiber, usually going to be bananas, some cooked rice, applesauce, and dry toast. Not the most exciting thing, but again, if you're trying to figure out why someone has diarrhea, that might be the way to go. We're going to really avoid any cooked fruit or vegetable might be okay, but cheeses can be really binding. So just it's easy to say if someone has diarrhea to maybe suggest cheese because most people know that it binds people up. But you don't also want that person going backwards in the other direction. Maintain fluid intake. That's going to be a big one. We're going to prevent fluid and electrolyte imbalances. Encourage oral intake. Water really is best. IV fluid and electrolyte replacement as necessary. And prevent skin irritations. Put them on a toileting schedule. Use barrier creams. Be gentle when you're helping them wipe because it can be really uncomfortable. So here's the medications I'm sure you've all been waiting for. Again, the treatment of diarrhea should really depend on the causative agent. So if it's just a strict diarrhea, nobody really knows why, you might see an antidiarrheal ordered to help treatment. These generally decrease motility and the propulsion and secretions in the lower GI system, overall helping to decrease fluid in the stool. They help to bind water, coat mucosa, and absorb toxins. So for our purposes, we're talking about Imodium, kaopectate, Pepto-Bismol, Lomotil. I'm saying those ones because I can't pronounce the generic names. So they are both on there. Again, when we are talking about medications, you don't have to know how to pronounce all of them, but you should be able to look at them and know kind of what they are as far as the generic name goes, because that's the way NCLEX is heading. And as we've talked about, Imodium is Imodium, but it can also be labeled as other things. So it's really important to know the generic name, because that generic name will never change. Brand names do change. So if you're going to stick something in your head, make sure it's the generic name for something. So if diarrhea is due to a loss of normal flora, such as an antibiotic therapy, we can administer active cultures called lactobacillus. That's also found in yogurt. And then antimicrobials. So if somebody does have C. diff, it's generally going to be treated with an oral vancomycin. We do not want to give antidiarrheals for this. If this person is particularly resistant to vancomycin, we might potentially try a fecal transplant, which is actually worse than it sounds. So this is for somebody who has really resistant C. diff. Generally, we need to repopulate their GI tract with healthy gut flora. So I won't go into detail on a fecal transplant. You can Google it. Just know it doesn't go in the way you think it does. It needs to be put in capsules, and the person needs to swallow it so that it repopulates the GI tract kind of from the get-go. So that's a fun one, right? And then something like diverticulitis might be treated with a drug called Flagyl. Again, we're looking to really identify the cause of something and treat it from there. So next we're going to talk about the opposite end, constipation. Again, many causes. Diet, poor diet, and physical inactivity are probably two of the bigger ones. Sometimes ignoring the urge to defecate will produce constipation in the long run. Stress can be constipating. Of course, any GI or neurological disorders, depending on what they are, can lead to constipation. And meds, we all probably know that opioids can lead to constipation for a lot of people. So signs and symptoms are going to be a change in the frequency and consistency of stool, a decrease in the usual frequency, and stool is generally going to be hard, dry, and difficult to pass. They might also have abdominal discomfort and some abdominal cramping, again, as their peristalsis is trying to move stool through and it's just not budging. So don't always just assume that cramping has to do with diarrhea. It might also have to do with constipation. We might hear hypoactive bowel sounds, and we might see a firm distended abdomen. Sometimes, if you're lucky, you can actually feel stool on palpation. So some potential complications of constipation. Hemorrhoids are a big one. These are the varicosities of the veins in the rectum. Straining to have a bowel movement may cause swelling in the veins and around the anus. They may be internal, which means they are inside the sphincter muscles, or external, where they are outside the sphincter muscles. Someone with chronic constipation can develop anal fissures, which are tiny tears in the anus caused by large or hard stool. Impaction, of course, is the mass of hard stool, which causes a partial obstruction or a complete blockage in any section of the bowel. And we have bowel obstruction right there behind it. If someone is impacted for long enough, they will generally develop an obstruction. Rectal prolapse occurs when the intestine actually protrudes from the anus. Straining to have a bowel movement can cause a small amount of the rectum to stretch and protrude outside of the anus. And then a fistula can also develop with chronic constipation. This is a tunnel basically that leads from one space to another. So if we're talking about constipation, a tunnel in this case would be probably from the rectum to either the bladder or the vagina, which is caused by trauma associated with severe constipation. So constipation is bad. Again, what are we going to do for it? We're going to determine and treat the cause. So this is going to be our first step. Usually, like I said, it's probably related to inactivity or poor food choices. So it's important that we counsel the patient to add in raw fruits and vegetables, eat more whole grain cereals and breads, add bran to their diet, drink lots of fluids. Fruit juices are particularly helpful because they contain fructose, which is a natural laxative. So in general, we want to be telling people between, 2 and 3 liters of water or liquid a day is going to be your best bet. So what can we do as nurses? We can offer frequent sips, make sure that they are drinking their water, make sure we're, keeping track of how much water they're taking in. If they like it hot, they like it cold, do anything you can to get them to drink more water. And of course, help the patient maybe design an acceptable exercise program. Might be walking, bicycling, swimming, anything moving is going to be good. It will ultimately help with constipation. In kind of inpatient settings, we're going to be looking at ambulating them as much as possible, especially after surgery. We're going to be repositioning them in bed. If they are not able to move their legs, we can do some passive range of motion. All of that stuff will help. Of course, we're going to offer them privacy and proper positioning to have a bowel movement. If they can, get them up into the bathroom, close the door, maybe get them kind of on like a high commode so that they're more comfortable. Upright is going to be more comfortable. It's really hard to have a bowel movement on a bedpan for most people. So get them comfortable, get them some privacy. It will probably help them. And then digital extraction. If the colon eventually becomes impacted with stool, digital extraction may be necessary. So we went over that in 1 of 3. I'm not going to go into much detail besides knowing it's not always in the nurse's scope. So make sure wherever you're working kind of has a policy on it, okay? As far as medications to help treat constipation, initial treatment might include a rectal suppository to help induce evacuation or the administration of a laxative. So a stool softener will probably be described if somebody is on constipating medications, like an opioid. Generally, we should also be looking at increasing fiber in liquids when they're taking a stool softener. As we should, at the first sight of constipation, we should really be increasing fluids and fiber. If that doesn't resolve the problem, they might be placed on a bulk-forming laxative like Metamucil, or daily stool softeners. So here we have just some kind of lists again. Be kind of familiar with these. Know really that they all have to do with making people have bowel movements. I wouldn't go into too much detail on the different types. It will be beneficial to know kind of when you're going to use one over the other. For example, you're going to use a stool softener kind of preventatively versus something like Miralax you're going to use when someone is already really constipated. So for bulking agents like Citracel or Metamucil, these cause water to be retained within the stool. It's important to make sure you're giving them with a full glass of water. Stool softeners draw water into the bowel to soften stools. They do not cause peristalsis. These are generally the drug of choice for those who use laxatives routinely. They absorb irritating substances and soften stools. Stimulant laxatives work directly on the intestines. They cause irritation, which promotes peristalsis and evacuation. Examples of that is going to be your bisacodyl or your Cinicides. An osmotic laxative is a hypertonic solution which helps draw water into the intestine from surrounding tissues, distending the bowel and causing peristalsis. An example of that is going to be lactulose or Miralax. And then saline laxatives, again, draw water into the intestine from surrounding tissues, which helps distend the bowel and cause peristalsis. Examples there are going to be magnesium citrate, milk of magnesia, and lubricant laxatives help lubricate the intestinal wall, allowing for smooth passage of fecal contents. Something like that is going to be a mineral oil, might be in the form of an enema. Enemas can also include fleet enemas or tap water enemas. And suppositories can include glycerine or bisacodyl, and again, depending on the type, just help get things going. I think generally they work by kind of irritating things and producing bowel movements that way. Next, nausea and vomiting. So persistent nausea and vomiting interferes with eating and overall hinders nutrition. Transient nausea is not treated, but when the disorder persists, medication with antiemetics and the administration of intravenous IV fluids are going to be necessary. Again, it's really important to identify the cause so that you can start to treat it from there. May be related to illness like a microorganism, an obstruction, or food poisoning. Sometimes overstimulation of the gag reflexes. So sometimes with thrush or a swollen throat, too much coughing or overproduction of phlegm can lead someone to be nauseous. It can be a medication side effect. It can be a result of anesthesia, pain, or overeating. Equilibrium disturbance is another big one, like motion sickness. Can be the effect of cancer treatment or stress. So pretty much anything can cause nausea, I think. We want to make sure as nurses that we are assessing the nausea. So if someone is nauseous and or with vomiting, we want to know what type it is. Is it projectile, which is what it sounds like? Is it intractable, which means it doesn't go away? Retching or dry heaves, that's when people are kind of trying to vomit, but they're not actually bringing anything up. And regurgitation, which we'll go into much later on. We want to be assessing the contents. So emesis generally is going to be green, yellow bile. You might see undigested food or medications in there. I'm going to try and pronounce this word. Hematemesis. Sounds good, right? Basically bloody emesis. There's blood in there. Vomit. Bright red might indicate some fresh blood. Generally going to be more from the esophagus. Might be from varices, which we'll go into. Emesis might also be coffee ground, which indicates a partially digested blood. So they might be having some bleeding in their stomach or upper GI tract. We want to be making sure we're assessing how much someone is vomiting. So we're keeping track of their I&O. How frequent it's happening, once a day versus every hour, can be really different. And of course, alleviating and aggravating factors. What makes it better? Sometimes some cool air, some ginger will make it better. Sometimes eating makes it better. Sometimes not eating makes it better. What makes it worse? Movement, feeling hot and stuffy, eating too much, not eating enough. Do certain medications cause it? So there's a lot that can make nausea worse. Not so much that makes it better, I think. So some potential complications of vomiting can be dehiscence. If a person has abdominal incisions, if they're vomiting forcefully, they could potentially rip their sutures or dehiss. Aspiration pneumonia, so if they vomit and inhale it, that ends up in their respiratory tract and they can get a pneumonia or a pneumonitis from that. Dehydration, of course, if someone is constantly losing fluid through emesis, or if they are unable to take in fluid because of nausea. This can result in metabolic acidosis. So the loss of hydrochloric acid in the stomach causes an increase in the pH. Signs and symptoms will eventually include anxiety, confusion, seizures, muscle cramps, or weakness. Just something to be aware of going forward. There are many more lab things you have to worry about to correlate a metabolic alkalosis. Just know if someone is having nausea and vomiting, that they're at risk for metabolic alkalosis. And then, of course, constant vomiting or nausea can ultimately result in nutritional deficiencies. If a long-term nausea or vomiting is present, nutrients are being taken in or absorbed. Treatment, again, you guessed it, determine the cause and treat it from there. Everything else is going to be really symptomatic, so we need to find out what is actually causing this nausea and treat it. We need to prevent aspirations to make sure we're sitting people in semi or high Fowlers, and then reduce their vomiting. Don't give them BiPAP, which is for respiratory issues. It helps force air basically into the lungs, so we don't want to be putting anybody on that, because if they do vomit, it will push vomit right into their lungs. As far as mouth care, make sure that their mouth is clean and comfortable as much as possible, and then we want to manage any aggravating factors. So do certain foods increase nausea? Any certain smells? If they do, try and manage those to the best of your ability. As far as medications, antiemetic medications, there's a table in your med-surg book which talks about all of the administration and nursing considerations for all of these. So I'm going to do a brief synopsis here. Antihistamines can work as antiemetics to help stop nausea and vomiting by depressing the central nervous system. Some of those are going to be Vistaril, Benadryl, Phenergan, Antivert, which is, I forgot. Sorry, it's for motion sickness. Dramamine. Jeez, there we go. That's the other one below it. Those all work to help prevent and to stop nausea to a certain degree. Compazine works by blocking chemoreceptor trigger zone, and in turn acts on the vomiting center of the brain, helps to stop nausea and vomiting. Zofran is probably the most commonly that I see in med-surg. This blocks serotonin peripherally, centrally, and in the small intestine. And then Reglan works to decrease reflux, helps stimulate gastric emptying, as well as raises the threshold of the chemoreceptor zone. So I think I'm going to stop this video here, and then the next video is going to be all about diagnostics. Exciting stuff. See you then.